Hello, and welcome to our NORA Chronic Disease Council webinar entitled Firefighting Exposures and Cancer, an overview of IARC's evaluation and its impact. My name is Todd Stickle. I am the co-coordinator and co-chair of the NORA Chronic Disease Council. The Chronic Disease Council, also known as the CRC, is part of the National Occupational Research Agenda. The Council's primary mission is to provide national and international leadership for the prevention of work-related cancer, adverse reproductive outcomes, cardiovascular, and other chronic diseases across diverse populations. NIOSH is the steward of NORA, and we partner with industry, labor, trade, professional organizations, and academia to facilitate important research, identify, understand, and communicate effective intervention and prevention strategies, and learn how to implement strategies to reduce occupational chronic disease. Our disclaimer states that the findings and conclusions of these presentations are those of the authors and do not necessarily represent the official position of the National Institute for Occupational Safety and Health, Centers for Disease Control and Prevention. We are pleased to announce that an archived copy of the full webinar in English and Spanish will be made available to the CDC YouTube channel later in late 2023. You will be able to share the link with friends and colleagues to watch this webinar in its entirety. Today, we have an exciting lineup of speakers, many who were key players on this IARC monograph working group. First, we'll have Dr. Paul Diemers, who was the chair of this IARC working group and is the director of the Occupational Cancer Research Center in Ontario, Canada. Next, we will have Dr. Kenny Fent, who is an industrial hygienist at NIOSH and leads the National Firefighter Registry effort here in the United States. Then we'll have Laura Bean-Friedman, who is an epidemiologist from the National Cancer Institute. Following her, we'll have Dr. David DiMarini, who is a scientist emeritus from the U.S. Environmental Protection Agency. Following David, we'll have Dr. Natasha Schaefer-Soll, who is a research assistant professor from the University of Miami in Florida. And last, we'll have Dr. Mary Schubauer-Berrigan, who is the head of the monograph program at IARC in Lyon, France. And with that, it is my pleasure to introduce Dr. Paul Diemers.
My name is Paul Diemers, and I'm the director of the Occupational Cancer Research Center in Toronto, Canada. I'm also a professor at the University of Toronto. I was also the chair of the IARC working group that evaluated occupational exposure as a firefighter, and I will give you a little background on IARC and the evaluation. For those of you who are not familiar with the International Agency for Research on Cancer, it's part of the World Health Organization, and its monograph program is the international leader for the evaluation of suspected causes of cancer. Suspected causes are classified into 4 categories, which you see here. Group 1, carcinogenic, Group 2A, probably, Group 2B, possibly, and Group 3, not classifiable for those that don't make it into any of the 3 groups. IARC first evaluated firefighting in 2007. 24 scientists from 10 countries concluded that firefighters are exposed to many known and suspected carcinogens, and based on an analysis of the studies of cancer available at that time, they identified testicular cancer, prostate cancer, and non-Hodgkin's lymphoma as having the strongest evidence. However, the epidemiologic studies were inconsistent and had other limitations, so the final evaluation was that firefighting was possibly carcinogenic to humans, Group 2B. 12 years later, in 2019, an advisory group met at IARC to recommend priorities for the next 5 years. For firefighters, the advisory group observed that there were many new studies. The new studies had fewer limitations, and the larger and longer studies had more consistent results. The new mechanistic studies available found evidence of increased DNA damage, oxidative stress, and other pathways. So the recommendation was for the reevaluation of firefighters within 2.5 years. In 2022, IARC reevaluated exposure as a firefighter. 25 scientists from 8 countries met in 3 subgroups: exposure, cancer in humans, and mechanistic evidence. In just a minute, you'll hear from a member of each of those subgroups to talk about the evidence that they reviewed and their conclusions. But the overall evaluation was that occupational exposure as a firefighter is carcinogenic in humans, group 1. The full monograph has recently been released, and a summary has also been published, and both are available on the IARC website. Thank you.
Hi, my name is Kenny Fent. I'm a research industrial hygienist with the National Institute for Occupational Safety and Health, or NIOSH. Today, I'm going to quickly talk about firefighters' exposures. Before we talk about exposures, I think it's important to acknowledge the different types of firefighters. The two main types of firefighters are structural or municipal and wildland firefighters. Wildland firefighters are trained to fight large vegetation fires or wildfires, and this includes digging lines and removing brush to stop the progress of those fires. Structural firefighters are trained to fight structure or vehicle fires, but they may also respond to vegetation fires and other emergency events. Firefighters may be career employees, seasonal employees, which is common for wildland firefighters, and/or volunteers. It's not uncommon for firefighters to be career at one department and a volunteer at another, or to begin their service as a volunteer and then transition to a career appointment. Firefighters may also further specialize. Some other subspecialties include industrial firefighting, airport rescue firefighting, training, and fire cause investigation. And each of these require specific skill sets and may have unique exposures. In terms of exposures, firefighters may be exposed to night shift work, UV radiation, especially for wildland firefighters, diesel exhaust, products of combustion, and other materials released during fires. IARC classifies agents into 3 groupings shown here at the bottom. Night shift work is classified as a probable carcinogen, group 2A. UV radiation is classified as a group 1 known human carcinogen. Diesel exhaust is also classified as a group 1 known human carcinogen. There are multiple products of combustion that are group 1 carcinogens, including benzene, benzoate-pyrene, formaldehyde, and vinyl chloride. It's important to note that vinyl chloride comes from plastics. Man-made materials such as plastics, foams, and other polymers will produce additional hazardous substances when burned, some of which are carcinogenic, like certain dioxins and furans. There are also other materials that are released during fires that are group 1 carcinogens. For example, asbestos, silica, and cadmium. Lastly, firefighters may use materials that contain hazardous substances, like aqueous film-forming foams, or AFFF, that have historically contained per- and polyfluoroalkyl substances, or PFAS. The way in which firefighters may be exposed to chemicals is complex. This diagram shows the potential exposure pathways for structural firefighters. Firefighters commonly wear self-contained breathing apparatus, or SCBA, during an interior attack of a structure fire, but may not wear SCBA outside the structure or may remove their SCBA once the fire is suppressed, in which case unprotected inhalation exposure is possible. Even when they wear SCBA, some chemicals are able to penetrate the protective barriers of their turnout gear and contact their skin, in which case dermal absorption is possible. After commencing firefighting activities, firefighters remove their turnout gear. Some contaminants on the turnout gear will off-gas and create additional opportunity for inhalation exposure. Some contaminants may transfer to the skin when firefighters are handling their gear or equipment, creating potential for additional skin exposure and absorption. Firefighters' hands, in particular, are likely to become contaminated, in which case ingestion exposure is possible, depending on hand hygiene. In addition, contaminated gear and equipment, if not properly decontaminated, may act as a reservoir for continued exposure upon future use. Diesel exhaust is also ubiquitous at fire incidents and other emergency responses. It's important to note that wildland firefighters do not wear the same type of protective equipment. Their protective clothing is lighter, and they often do not wear any respiratory protection. They also may be deployed to a wildfire for weeks at a time with limited access to showers or clean replacement protective clothing. Wildland firefighters also commonly use fuel or gas-powered equipment like chainsaws and drip torches. Hence, they may be exposed via the inhalation, dermal absorption, and ingestion routes. As you can see, firefighters of all types may be exposed to carcinogens during fire responses and other work activities, and these exposures are not just chemical in nature. Contamination of gear and equipment is a big concern for take-home exposure and cross-contamination. Firefighters in specific disciplines may also have unique exposures, for example, use of aqueous film-forming foams, and man-made materials when burned will create additional hazards, such as vinyl chloride or dioxins. Understanding the exposure pathways helps identify potential control interventions to reduce exposure. And fortunately, many departments have implemented new policies and procedures aimed at reducing these exposures. Thank you.
Hello, my name is Laura Bean Freeman. I am a senior investigator at the U.S. National Cancer Institute and was a member of the epidemiology subgroup at the recent IARC monograph evaluation of occupational exposures as a firefighter. In the 2022 IARC review, there were many studies that had been conducted since the previous review in 2007. The working group identified 52 cohort and case control studies, 12 case reports, and 7 meta-analyses that were potentially applicable. Because of the large body of epidemiologic evidence, the IARC working group conducted its own meta-analysis of the most informative studies to evaluate cancer at 12 sites. A meta-analysis is a method whereby results from the individual studies are combined to derive an overall estimate of effect, which can be very useful as it allows researchers to consider results from studies conducted in different settings. In total, the working group determined that there were more than 30 cohort studies from around the world that were the most informative, in essence, the highest quality. In their evaluation of the epidemiologic evidence, in addition to the meta-analysis, the working group reviewed the quality of the individual studies, including their strengths and limitations, possible sources of bias, such as those that might be caused by increased medical surveillance, and potential confounding, such as differing rates of important lifestyle factors like smoking among the comparison groups that might explain observed differences. After a thorough review, the working group determined that there was sufficient evidence that occupational exposure as a firefighter was causally associated with cancer at 2 sites, mesothelioma and bladder cancer. For mesothelioma, there were 7 studies that investigated incidence rates in firefighters and that were included in the meta-analysis, which revealed a 58% increase in risk compared to the general population. Firefighters may encounter asbestos in their jobs, which is a plausible causal agent. Asbestos was historically used in building materials and has been shown to cause mesothelioma in other settings, although not specifically reviewed in this monograph. For bladder cancer, there were 10 studies included in the meta-analysis that evaluated cancer incidence, resulting in a 16% increase in risk in firefighters. While this increase is modest, there was consistency amongst the studies in the meta-analysis, and also consistency with 2 other high-quality cohort studies with a more expansive definition of bladder cancer and with mortality studies that were also not included in the meta-analysis. It was determined that this increase was unlikely due to other factors or bias in the epidemiologic studies. In addition, firefighters have exposure to known or suspected bladder carcinogens such as polyaromatic hydrocarbons and soot. There were 5 additional sites for which the IARC working group determined that there was limited evidence of a causal association. These sites include cancers of the colon, prostate, testes, melanoma, and non-Hodgkin lymphoma. This means that while there was some credible evidence of increased risk between firefighting and these cancer sites, bias, chance, or confounding could not be ruled out. In particular, surveillance bias or medical screening was a concern for prostate and colon cancers. In addition, there was evidence that lifestyle and physical characteristics may have confounded the relationship between these cancers and firefighting. For all other cancer sites evaluated, the epidemiologic evidence was determined to be inadequate. The working group in particular noted a reduced risk of lung cancer overall. This was likely due to lower rates of smoking in the firefighting populations and bias in the epidemiologic studies. And while there was some evidence of an increased risk of thyroid cancer, this was attributed primarily to increased medical surveillance in firefighters compared to the general population. In summary, there were 2 cancer sites that the working group determined had sufficient evidence of a causal relationship between occupational exposure as a firefighter. There were an additional 5 sites for which there was some credible evidence of an increased risk, but for which chance, bias, or confounding could not be ruled out. These included cancers of the colon, prostate, testes, melanoma, and non-Hodgkin lymphoma.
Hi, I'm David DiMarini, and I'm going to describe the mechanistic evidence for the carcinogenicity of occupational exposure as a firefighter, as described in IARC monograph, volume 132. So first, the background. Mechanistic evidence explains how an agent causes cancer. IARC considers 10 mechanisms by which agents can cause cancer. The working group for this monograph found strong evidence for 5 of these mechanisms by which occupational exposure as a firefighter causes cancer. So let's review those 5 mechanisms. The first is genotoxic. Firefighting damages DNA in cells in the blood and the mouth, and it puts chemicals in the blood that cause mutations in DNA. Thus, firefighting is genotoxic. Second, induces epigenetic alterations. Firefighting turns cancer-associated genes on or off inappropriately. Thus, firefighting induces epigenetic alterations. Third, induces oxidative stress. Firefighting produces toxic forms of oxygen in the blood that damage DNA and other molecules. Thus, firefighting induces oxidative stress. Fourth, induces chronic inflammation. Firefighting results in increased levels of inflammatory proteins that damage tissues and remain long after fighting a fire. Thus, firefighting induces chronic inflammation. And fifth and finally, modulates receptor-mediated effects. Firefighting puts chemicals in the blood that bind to proteins that can activate cancer genes. Thus, firefighting modulates receptor-mediated effects. Finally, there are 2 key takeaways. The first is that the mesothelioma, which is cancer of the cells lining the lungs and other internal organs, as identified by the epidemiology subgroup, is likely due to asbestos exposure, most probably from structural fires. The bladder cancer, also identified by the epidemiology subgroup, is likely due primarily to aromatic amines, as well as to nitro-PAHs and PAHs. All 3 compounds, aromatic amines, nitro-PAHs, and PAHs, are interrelated, and all are formed in combustion emissions, and all are important classes of carcinogens in combustion emissions.
Hello, my name is Natasha Schaefer-Solly, and I'm a nurse scientist and assistant professor at Sylvester Comprehensive Cancer Center at the University of Miami. As you previously heard from my colleagues, the IARC monograph reevaluation examined critical research related to firefighter exposure, epidemiology, and mechanisms of cancer to determine firefighters' new classification. I will now share with you some key recommendations for firefighter cancer prevention at both an individual and organizational level, as well as report on research interventions that focus on cancer prevention in the fire service. For cancer prevention at an individual level, there are several modifiable risk factors in which firefighters can implement into their lifestyle, including completing an annual physical exam, which includes a comprehensive history and physical exam, as well as laboratory testing and assessment of all body systems, including a mental health screening. Completing the recommended cancer screenings based on the American Cancer Society, the U.S. Preventative Services Task Force, and NFPA 1582. Cancer screening should be tailored to the firefighters based on their risk. Also maintaining a healthy nutrition and weight by limiting sugary and processed foods, participating in regular physical activity, avoiding risky behaviors, including no tobacco or drug use, limiting alcohol consumption, and wearing sunscreen on a regular basis. Lastly is good sleep hygiene. We know that inadequate sleep has been demonstrated to increase stress hormone levels as well as inflammation. At an organizational level, there are several things firefighters and fire departments can do to decrease firefighters' risk for exposure. Some things include completing decontamination practices. This includes on-scene decon following a fire or hazmat incident, setting up rehab in a cold zone, and cleaning exposed areas, including hands, face, and neck, prior to eating or drinking. Also reducing carcinogenic transmission by showering within the hour, not having gear or PPE in the living quarters, and transferring gear in airtight containers when in personal vehicles. Also promoting washing safety gear on a regular basis, including having second sets of personal uniforms and using station washing machines for all station clothing. Consistent use of SCBA and PPE, as well as creating established policies, developing and implementing a written policy for cancer risk reduction activities within your department may help increase cancer prevention strategies. Lastly is creating a health and safety committee with a dedicated health and safety officer to advocate for cancer prevention activities within the department. Some examples of cancer interventions in the fire service have included a study looking at workplace-based sleep health program, incorporating sleep health education and sleep disorder screenings to improve firefighter health and safety. Also, decontamination processes. We saw that field decontamination using dish soap, water, and scrubbing was able to reduce polyaromatic hydrocarbon contamination on turnout gear by an average of 85%. Another study looking at multi-gas detectors in a warm zone showed that firefighters should implement strategies for multi-gas detector use as well as respiratory protection within warm zone areas. Lastly is looking at cultural change. This study presented a theory-based communication intervention tailored to the unique context of high reliability organizations. Norms and self-efficacy were the strongest predictors of the current behavior, specifically looking at decontamination practices to reduce exposure. Some key takeaway messages from this section are 1. Cancer risk awareness. Firefighters should be aware of their occupational risk factors for cancer and understand ways to mitigate their risk at both an individual and organizational level. 2 is their annual physicals and screenings. A key to cancer prevention is early detection and cancer screenings based on their occupational cancer risk. And lastly is cancer interventions. Cancer health interventions are critical to understanding the needs of firefighters and provides opportunity for change.
My name is Mary Schubauer-Berrigan, and I am head of the IARC Monographs program. Here I present a brief overview of the impact of the IARC Monographs evaluation of the carcinogenicity of occupational exposure as a firefighter. IARC has been evaluating the impact of our cancer hazard classifications, including of firefighting as a carcinogenic occupation. Today, I will mention 3 efforts. First is the impact on the scientific community. Second is the broader impact of the evaluation across the whole internet. Third, I will give some specific examples of impact from around the world. We first looked at scientific citations of the meeting summary published in The Lancet Oncology. We searched Google Scholar for all scientific articles that cited this summary, which was published in June 2022. We found 57 articles published between then and mid-July 2023. Next, we searched the internet for mentions of IARC with firefighters and cancer. To look at longer-term impact, we searched just the first half of 2023, excluding the scientific references found in the first search. We found 57 unique websites mentioning the evaluation. What did we find? More than 1/3 of the scientific papers focused on exposure assessment, especially for PAHs. There were also many papers related to exposure reduction and to cancer epidemiology. There were few studies describing cancer screening or compensation, and none related to legislation. The web pages on the internet referring to the IARC evaluation were much more focused on exposure control or reduction, contamination of protective gear, and especially issues related to compensation. More than 1 in 5 of the web pages referenced legislation that had been undertaken to help firefighters. PFAS exposures were of greatest concern. IARC created an infographic to go along with the meeting summary. This has been shared hundreds of times online and in social media. It has even been printed as a large poster and displayed in fire halls. Many of the internet citations came from firefighters unions, like the Fire Brigades Union in the UK. They cited the IARC evaluation as bolstering the case for better decontamination methods, improved health screening, and recording of exposures. In this example from Saskatchewan, Canada, the emphasis is on improved training and on prevention methods to reduce exposures to carcinogens among firefighters. I hope in these few examples you have gained a sense of the impact of the IARC evaluation of the carcinogenic hazard of firefighting. We thank our entire working group for their exceptional contributions.
We hope that you have enjoyed today's webinar. The invited speakers would like to acknowledge the entire IARC Monographs Volume 132 Working Group. Special thanks are given to Mary Schubauer-Berrigan, Nat DeBono, and Soline Quinhen. Lastly, thank you to the entire IARC Secretariat for their efforts in this evaluation. The speakers would like to share some key scientific references for you if you would like to learn more about specific topics with firefighting exposures and cancer, including the full citations of the evaluation and complete monograph. Next, we would like to take this opportunity to encourage all firefighters to join the National Firefighter Registry to reduce cancer in the fire service. Please share the link that you see on the screen with your firefighter colleagues, friends, and family. Thanks for attending today. If you would like to learn more about the NORA Chronic Disease Program, please feel free to visit our webpage or send us an email at these addresses. Enjoy the rest of your day.